Hi folks, Professor Delford here. We're doing our live lecture here for week 2. It is the 18th of May at 3:30 p.m. So let's go ahead and do a screen share, share computer sound, and optimize video. All right. We need to turn off the computer speaker so you don't have echo. Zoom does a great job of reminding me to do that, and I appreciate that. And then let's go ahead to the review sheet. What I've decided to do this week is to go to the latest items. These are the roughly 50 items that have been seen most recently on the TMC exam. So the things that you can definitely expect to see when you take the exam after graduation. We don't have the exact questions, of course we don't, but we do have the topics that you need. So let's go ahead and record this video right now. 6:54. Your home care patient's on 6 liters by cannula, badly wants to attend his grandson's football game using e-tanks. But the problem is 6 liters is a pretty high flow rate. He doesn't want to run out of oxygen, okay? So how many e-tanks will he have to take with him? Well, let's see what 1 tank will do. 1 tank, 2,200 pounds times 0.3 tank factor, divided by 6 is 110 minutes. That would be 660. 2,200 times 0.3 is 660, divided by the flow rate of 6 is 110 minutes, and not quite 2 hours, okay? Well, 4 hours is 240 minutes, divided by 111 minutes per tank, so it really takes 3 tanks for the patient to safely have enough oxygen. 2 would not quite do it. And we don't want to even run close to running out of oxygen for the patient. So it would take 3 tanks to watch the football game safely and get home. So there you go. All right. That type of calculation you can expect on the test. Gold standards for asthma, very important for the TMC exam. I will not have time to completely cover those for you. Otherwise, we would not have enough time to finish this. But they're right here, GinaAsthma.org. And these are the asthma guidelines that you definitely need to know. ACLS protocols, you need to know all of them. The ones that are most commonly seen are the things that you would expect, and those are ventricular. I've got that misspelled. Let's fix that right now. CULAR, tachycardia, with a pulse, and ventricular tachycardia without a pulse. Okay, so the protocols are listed right here. The VTach without a pulse gets defibrillated, as you know. VTach with a pulse might get cardioverted with the synchronization on the R wave. But use that link, which you have already received. I already sent this to you. Number 657, to measure weaning parameters, therapists use a manometer. That's the NIF or MIP gauge. I know you've used it, but you may not have heard it called a manometer. So now you know, manometer is the term for that NIF or MIP gauge that we measure the maximal inspiratory pressure with. And the right respirometer is known on the test as a vein respirometer to measure tidal volume and vital capacity. And probably the reason they do that is that Wright is actually a brand name. At the hospital, you'll likely hear NIF meter, right respirometer, but manometer and vein respirometer are the terms used on the test. A test to rule out pulmonary embolism. This is very important. You need to know you should order the D-dimer test. D-dimer goes with pulmonary embolism. D-dimer, pulmonary embolism. Normal range for pulmonary capillary wedge pressure, well, it's 4 to 12. This is the Swan-Ganz catheter, which we know is on the test is the balloon-tipped flow-directed pulmonary catheter. And the balloon would be inflated. That means it wedges in the pulmonary artery, and we have a pressure about 4 to 12. They might give you a patient with a wedge pressure of 20 or 25. That would definitely be pulmonary edema. So you definitely need to know that. Number 660, your patient has a large pneumothorax, also displays hypotension. What is most likely causing this? Well, what's happening is the internal tourniquet effect caused by the pneumothorax. The pressure builds, that decreases venous return to the heart, and then the cardiac output goes down. So decreased venous return to the heart is the answer, and that causes decreased cardiac output. I'm going to add that. There we go, causing decreased cardiac output. Your patient complains of difficulty in initiating the IPPB breath. Well, that's a problem of sensitivity. You would adjust the sensitivity to make it easier for the patient to initiate a breath. All right. IPPB treatments are still on the test. I know we don't do them very often in clinic anymore, but trust me, they're still on the test. Many students have seen them. So it's the sensitivity setting that would allow the patient to initiate the breath more effectively. Pleural drainage system with a pneumothorax doesn't show any bubbling in the suction control chamber. That's a problem. There should be bubbling there. That's the air coming out of the pneumothorax. After checking the regulator to confirm it's on, what would you check next? Check the entire system for leaks or obstructions. That's very important. If you don't see bubbling, very likely there is a leak or an obstruction. Could be a blood clot, could be a disconnect or a suction canister that's not tight. Any of that could cause it. Your patient with a flail chest would show which ABG finding? Well, they would show a decreased pH. That's because of the poor ventilation, a respiratory acidosis, and a decreased oxygen saturation. Okay, so you've got, actually let me add to that item, decreased pH. High PaCO2 and decreased PaO2 and SaO2. That covers all of them. I want to do a better job for you with that item, so we've improved it. In which condition would a ventilation scan appear normal, but a perfusion scan demonstrate no blood flow? That's pulmonary embolism. That's why we do a ventilation perfusion scan, a VQ scan, and that is because we want to see the difference between ventilation, which is normal with a pulmonary embolism, and perfusion, which is not. Okay, your patient has the following volume ventilator settings. Got a tidal volume of 550, a PIP of 29, high pressure limit of 55, low pressure alarm of 20, low tidal volume alarm of 450. The thing here that doesn't make sense is that high pressure alarm, which is too far above the PIP. So you want to reduce that high pressure alarm. Take a minute to look at that, be sure you understand it, but we definitely want that high pressure alarm only about 10 above the patient's current PIP. That's actually a very good question. Whoever wrote that question, that's an important concept. Okay, you ask your patient to take his deepest breath in and then exhale completely. All the way in, all the way out, that's vital capacity. So you may have a question which is describing in words the vital capacity. They could also do inspiratory capacity. You could say, have your patient exhale to the resting level and then take the deepest possible breath in. That would be inspiratory capacity. But I would think maybe vital capacity would be more likely on the test. Pulsus paradoxus, which develops after chest trauma, is cardiac tamponade. What happens there is that fluid builds up in the sac around the heart, and consequently the heart cannot pump correctly. We get a change in pulse, a change in pulse pressure with respiration, and that is pulsus paradoxus. All right, common cause of respiratory alkalosis. This is a key concept. The patient may be hyperventilating and causing themselves respiratory alkalosis because they're hypoxemic. So one way to fix respiratory alkalosis in many patients is to improve their oxygenation. Think of that, folks. That's simple enough. If the oxygen's low, the patient will hyperventilate, trying to get more oxygen into their blood. So we fix the hypoxemia and thereby fix the respiratory alkalosis. Common cause of increase in the patient's peak inspiratory pressure. Well, bronchospasm would probably be number one. I would also add patient needs to be suctioned. Let's go ahead and add that. So those two would certainly be the most common reasons that the PIP goes up for a patient on the ventilator. Patient's admission diagnosis is dehydration. What physical findings would you expect? Well, inspissated secretions are because they're dried out. Inspissated, dried out secretions would definitely happen, and also poor skin turgor. You pinch the patient's skin on the back of their hand, and it doesn't go down immediately. It stays pinched, elevated. That is poor skin turgor. Amyotrophic lateral sclerosis, ALS, well, that is Lou Gehrig's disease, and you have to know it's Lou Gehrig's disease in order to answer the question right. It's a neuromuscular problem. You would watch MIP, vital capacity. The patient would benefit from an MIE or coffulator device. Okay, ALS is Lou Gehrig's. It's neuromuscular, MIP, and vital capacity. Review your ventilator settings for a specific disease or diagnosis like Guillain-Barré or myasthenia gravis. That would be assist control ventilation. Pneumothorax would be chest tube, then pressure control ventilation. Pleural effusion, assist control and SIMV, and ARDS, lung protective strategy, and permissive hypercapnia, maybe proning as well. So different diseases do get different treatment on the ventilator, and that is very helpful for you to know about. Infection control, how about a metal laryngoscope blade? How would you disinfect it? That would be 2% glutaraldehyde. What would you clean equipment with if it was used of an active TB patient? It must be disposed of or autoclaved if possible. I am going to add ethylene oxide as one more alternative. If you have an instrument that cannot be autoclaved and you don't want to dispose of it, then you could use ethylene oxide to sterilize it. We don't do that a lot anymore, but we could. Okay, so chest x-rays, go back through the chest x-rays in this review sheet. And for every one of them, don't just say, what is it? But also say, how would I treat it? That is a very common thing that's showing up on the exam. Oxygenation index, I may have mentioned this one before, but many people are seeing this on the test. Let's make that a little bigger. It's just FiO2 times mean airway pressure divided by PaO2. And I think what you're likely to see on the test is not an actual calculation, but just which of these is the formula. As far as when is it used, it's used to decide about ECMO. Let me add that here. Often used to determine the need for ECMO therapy. All right. Heart rhythms, well, we've got bradycardia treated with atropine and ventricular fibrillation, immediate defibrillation with 120 to 200 joules. You do need to know those joule levels, and that's the kind of thing that, boy, you got so many numbers to remember, but that one you've got to know. Where do you start the defib? It's 120 to 200. AFib, treat it with verapamil or cardioversion and sync on the R wave. That's atrial flutter. Atrial fib would be the same, by the way. Sync on the R wave and do the cardioversion. Let's go ahead right here to heart blocks. The heart block poem. Okay, I love this thing. Princeton Surgical Group came up with this. If the R is far from the P, then you have first degree. Longer, longer, longer drop, then you have Wakey-Bach. If some P's don't get through, then you have Mobitz 2. And if the P's and Q's don't agree, then you have third degree. The heart block poem. I absolutely love that. And just take a couple minutes and look at that. You'll see that it, not only is it cute and memorable, but it's exactly right. And it will help you to remember which heart block. I'm going to leave it on this slide for a couple minutes and just go down here and let you see the treatment as well. Atropine for first degree, atropine or pacemaker, depending on severity, for second degree, and third degree pacemaker. Let me leave it on this for a minute while you study that. Okay, let's move to the next thing. Determining heart rate from rhythm strip, you've got to know this. Determining heart rate from rhythm strip, it's the number of large squares between QRSs. The number of large squares between QRSs, divide that into 300. So for example, if you look at that first one, you've got 1, 2, 3, 4 large squares between the QRSs. 300 divided by 4 is 75. If there were only 3 large squares between QRSs, that'd be 300 divided by 3, and that would be 100. Only 2 large squares, that'd be 150. 300 divided by 2 is 150, and that would be tachycardia, obviously. Let's say you had 6 large squares. 300 divided by 6 is 50. So that would be bradycardia. Let me leave it on there for just a minute and make sure you have that concept, because very likely you'll be calculating the heart rate on a strip during your TMC exam. Now let's move ahead. We're going to do some blood gas. Finish this. Number 680, when adjusting ventilator settings to fix ABGs, the key concept is to fix ventilation first. Once you fix ventilation, likely the oxygenation will be fixed in the process. 7.29, 67 CO2, 50 O2, and bicarb normal. Here you have a problem with ventilation. So you want to increase the ventilation first to correct that elevated PaCO2. Likely the PaO2 will come up in the process. You do not need to adjust FiO2 or PEEP. 681, your intubated patient, end-tidal CO2 suddenly drops from 36 to 0. What on earth could cause that? Well, the main things that could cause that will be a disconnect, an obstruction, or if the patient cardiac arrested. Because if they're not pumping blood, then you don't get the CO2 coming back to be measured. All right. Your patient receiving PEP therapy complains of pain during treatment. What would you do? Well, definitely stop the treatment. There's no reason that you should have pain during PEP therapy. So if you've got that, something is wrong. You could speculate pleurisy, pneumothorax, small pneumothorax maybe. I don't know, but acute bronchitis or something like that. But you would definitely want to stop the treatment and find out why. Let's say that the patient's CVP is normal, wedge is normal, but the pulmonary artery pressure is elevated. Well, that, folks, is hypertension. Pulmonary hypertension, definitely. Let's say the CVP is high, but the wedge is normal and the pulmonary artery pressure is normal. That could be fluid overload. The nurses could have simply run too much fluid too fast, and we do see to have that happen from time to time. So, all right. And number 685, we've got CVP normal, wedge high, pulmonary artery pressure normal. That would be CHF or pulmonary edema. The wedge pressure is the key indicator. The wedge pressure is the key indicator of pulmonary edema or left heart failure, which is CHF. Let's actually add left heart failure. because some students have seen that term used, left heart failure, which is CHF or pulmonary edema. Chest x-ray terminology, a cavity is tuberculosis. That one you probably knew. Butterfly pattern is pulmonary edema. These are really important. I'm going to leave them on the screen for a minute. Cavity, tuberculosis. Butterfly pattern, pulmonary edema. Hyperlucent emphysema or pneumothorax. Okay. Let's just let you study this for 1 minute. Okay, normal hemoglobin, 12 to 16. That would be milligrams per deciliter. Let's put the units on just in case. 12 to 16. Hemoglobin of 8, that would definitely be anemia. Hemoglobin of 20, polycythemia. Too little hemoglobin is anemia, too much polycythemia. Polycythemia is often seen in long-standing chronic lung disease. The patient actually makes more hemoglobin to compensate for their lack of oxygen. With the low hemoglobin, it's blood loss from somewhere, or the patient is not making enough hemoglobin. It could be either of those things. Okay, potassium, very important. Potassium 6.1. Normal range 3.5 to 5.5, so 6.1 is pretty high. What would you recommend? Neb treatments with albuterol. You know, we jokingly say that albuterol is good for everything, you know, all better all, they call it. But with a high potassium, it does work. It actually brings down the patient's potassium. That was discovered by accident, but it has helped many patients because we could bring down their potassium. Then there's the spirogram with numbers. And here are the different combinations. This is how you're likely to see it on your test. I think I'm actually going to need to shrink that a bit to get it all on the screen. But there we go, spirogram with numbers. 1 plus 2, well, 1 is the volume above tidal volume. That's inspiratory reserve volume. 2 is tidal volume. So 1 plus 2, give you a minute to answer. Inspiratory capacity. 1 plus 2 plus 3, well, that's the same 2 plus expiratory reserve volume. Those three taken together, 1 plus 2 plus 3, vital capacity. 4 is also vital capacity. It's just the same total volume. 3 plus 5 is ERV plus RV, that's FRC. And 4 plus 5 would be your total lung capacity. Now take a couple minutes here and make sure you understand that, because you're going to have several questions on the test about this spirogram. Take a few minutes and study it, please. All right, let's go ahead. That's the last item. Okay, that is the last item. So what we're going to do is now look at the formulas which people are seeing on the test. Certain formulas you need to know, but the good news is you don't need to know all 50 formulas that we have in respiratory. You need to know these formulas. Ideal body weight. It's 50 kilograms plus 2 times the inches over 5 feet in height. And then if it's a male, add 2 more kilograms. Let's say a 5'4" female, just as an example. 50, everybody gets 50 as long as they're 5 feet tall, plus 2 times 4 gives you 58. All right? You don't add the extra 2 because this is a female. Tidal volume would then be 8 times that number. In this case, it would come out 464. You know, it doesn't have to be exactly 464. It could be 450 or 475, but something in that range. All right. What we've got here is Mean pulmonary artery pressure. Well, any mean pressure is going to be twice the diastolic plus once the systolic divided by 3. That's because your heart is in diastole twice as long as it is in systole, okay? So take an example, and you could be given this very question. Systemic mean arterial pressure, 2 times 80 plus 120 divided by 3, it comes out 93. You could be asked on the test to calculate a mean pressure. Could be either mean systemic pressure or mean pulmonary artery pressure, but that would be the calculation. Cardiac index has been mentioned. Students have seen this on the test. You know, we don't know what question is asked about it, but we do know that it's something about cardiac index, so you need to study this. Cardiac output divided by body surface area is cardiac index. So normal cardiac index is roughly 2.5 liters per minute per square meter. Liters per minute per square meter, those are the units. Normal cardiac output is about 5. So normal cardiac index is about 2.5. The units, liters per minute per square meter. Alveolar air equation. Here's the short form that we're going to recommend you use for the test. It's just FiO2 times 760 minus 47, that's always 713, and then subtract the PaCO2 divided by 0.8. Some people use PaCO2 times 1.25. It's the same exact thing. So let me give you that option. PaO2 equals FiO2 times 760 minus 47 minus the PaCO2 times 1.25. Either way. So on pure oxygen, that comes out 1 times 760 minus 47 minus 40 divided by 0.8, 713 minus 50, 763. So on pure oxygen, that's how we come out. All right. Then if the PaO2 was 200, your AA gradient would be 663 minus 200, 463, sorry. All right, alveolar equation, you need to know it. AA gradient is just taking that and subtracting the arterial oxygen, and we've shown that for you here. PF ratio is kind of interesting. This is a relatively new calculation. PaO2 divided by FiO2. Note the FiO2 must be expressed as 0.21 or 0.50, not as 21%, 50%, or 100%. So for example, a normal patient, you'd have about 100 PaO2 on room air, 21%, so that's 476. That's PF ratio. You could see that on the test. Let's look at dead space to tidal volume ratio next. VDVT is PaCO, PiCO, PaCO. PaCO minus PiCO divided by PaCO. Here's your arterial CO2 minus the exhaled CO2, the end tidal CO2, and then divide that by the arterial CO2. Example then would be like 40 minus 30 over 40. Typically, arterial CO2 would be about 40, end tidal about 30 divided by 40. So that would be 10 over 40, a VDVT of 0.25. Yeah. So that means 25% of each tidal volume is dead space. That's a useful calculation. You could be asked to calculate that one on the test. FiO2 for various nasal cannulas. Well, folks, we already covered this in the first lecture, but it's 4% per liter, and then add room air. We've done several practice items with duration of cylinder flow. That could definitely be on the test. And also in the lectures, we mentioned minute volume. That could be on the test. It's just frequency times tidal volume. Alveolar ventilation, the only difference is that you need to calculate, you need to use dead space and subtract dead space from tidal volume before you multiply. Dead space, 1 milliliter per pound of ideal body weight. Dynamic compliance is tidal volume divided by pip minus PEEP. And we show you how to calculate that. Hey, static compliance is tidal volume divided by plat minus PEEP. I think you know that one. Airway resistance, pip minus plat over flow. We show you the calculation there. And then RSBI could very well show up on your test. That's going to be the patient's respiratory rate divided by tidal volume, but it's got to be 0.2 liters, not 200 milliliters, okay? All right. RSBI should be less than 105 for successful weaning. Lung volumes adding up to capacities. Let's just shoot that on down to the next page because I know that's going to take a graphic here. So look at this graphic. This is exactly what we just went over. And look at all the different combinations. We're actually just going to leave it on there for a second and let you review that. Okay. Oxygenation index, we just covered that just a few minutes ago. It's FiO2 times mean airway pressure divided by PaO2. Okay, and then the last thing I wanted to mention here before we do some blood gas practice is here is the entire review sheet divided up by the areas of the detailed content outline. So let's say you're weak on evaluating procedure results, maybe like interpreting PFTs, that's a weak area. Then what you would do is go to that group right there, D on your screen right there, and those are the review sheet items that allow you to practice the evaluation of procedures. Let's say that infection control worries you, don't feel strong about that. Then there is B, 2B. Those are the items that will be specifically on infection control. I think you're getting the idea. And here is area area 3. And this is one that many people need practice with. This is where you've got your modifying interventions, things like changing ventilator settings to fix blood gases. That's a really important aspect. Okay. Folks, that brings you up to speed on the review sheet at this time. So what we're going to do here is we're going to do some blood gas practice to finish this thing up. All right, here we go. This is going to be ABG Ninja. ABG Ninja. All right. ABG Ninja, practicing blood gas interpretation. We're also going to talk about how to fix these blood gases. That, I think, is one of the things that's difficult for some students, probably for most students, is fixing blood gases. So 7.54, 23, and 19. Let's do this one together. 7.54, alkalosis, right? CO2, well, CO2 is an acid substance, and this is low. 35 to 45 is normal. So when an acid is low, that's alkaline. So we've got respiratory alkalosis. This patient is hyperventilating, okay? Is there compensation? Yeah, there is, because the bicarb has come out of its range to try to compensate. That's metabolic acidosis compensating. Is it partial or full? Well, it's partial, because if it was full, the pH would be back within normal limits. So what we've got here is a respiratory alkalosis partially compensated by a metabolic acidosis. Okay, and we've got it right. But now let's talk about how to fix it, okay? What we've got is a patient who's hyperventilating. So if they're on a ventilator or BiPAP, we need to decrease ventilation. We need to decrease ventilation, And we could do that by bringing down the rate, down the tidal volume. If it's BiPAP, we could bring down the gap, reduce the gap between inspiration and expiration. That's how we would fix that blood gas. Okay? Let's try another one. This one will be yours to try, and we'll just give you about 3 minutes to interpret it, and then we'll talk about how you would fix it. Okay, let's see how you did. 7.50, definitely alkalosis, right? CO2 is low, so that's going to be a respiratory alkalosis. And is there compensation? There's a little, just a little compensation. It's metabolic acidosis compensating. The pH is still outside of range, so that's partial compensation. So, folks, we have the same kind of blood gas that we had with the last one. This is a patient who's hyperventilating, so we need to decrease ventilation. With the volume ventilator, you would decrease tidal volume or respiratory rate. If the tidal volume is where you want it, if it's correct for the patient, then you would decrease rate. If it's a pressure ventilator, you would decrease peak inspiratory pressure. If it's an oscillator, let's talk about that. You would decrease amplitude to fix this blood gas. All right, now let's make sure we're right. Pretty sure we are. All right, and there we go. Let's try another one. I think we got time for maybe 3 more of these. Interpret that, please, and I'll be back in about 3 minutes to discuss it with you. All right, let's take a good look here. pH 7.45. Now that is alkaline. It's within normal limits, but it is on the alkaline side of 7.4. The CO2 is 52. That's an acid problem that does not match the pH. Okay? The bicarb is alkaline. Normal's 22 to 26. This is quite high at 35. So we have a metabolic alkalosis. A metabolic alkalosis, let's put that in here first, metabolic alkalosis. And the patient is compensating? Yeah. The CO2 has come out of its range trying to compensate, and by golly, it has compensated. It has compensated. The pH is back within normal limits. So we have a fully compensated metabolic alkalosis. Another way of saying that would be a metabolic alkalosis fully compensated by a respiratory acidosis. And it is correct. So the interesting thing about this is that, well, first, we don't see it very often. We don't see a high bicarb causing alkalosis like this very often. That could be a kidney problem, maybe. It actually could be COPD, where the patient has a high CO2 and they've slightly overcompensated with their bicarb. So actually, we wouldn't do very much to fix that because this patient has done their own compensation. Let's do another one. 7.45, 22, and 15. Folks, I'm going to skip that one because it's the same type that we've seen before. This is respiratory alkalosis with metabolic acidosis compensation, which is full. I want you to benefit from a different kind of blood gas. That one matches what we've already seen. Okay, 7.54, 41, and 34. That's a different blood gas. So let's give you time to interpret that, and then we'll be back. Okay, 7.54, definitely alkaline. The CO2 is not the cause. In fact, the CO2 is within normal limits. So we have a metabolic alkalosis. Is there compensation? No. The CO2 is completely within normal limits. It has not moved at all to compensate. So we say no compensation, no level of compensation. The only thing I can think of here is I've seen some patients who took too much antacid, for example, like Mylanta or Maalox or something like that. Let's say they've got stomach discomfort and they take too much of it. They could actually wind up in an uncompensated metabolic alkalosis. Usually that patient solves the problem themselves by vomiting, honestly. So, all right, let's try another one, 729, 61, 28. This one is a very important example for respiratory therapists. This is something we deal with all the time. So I'll be quiet while you figure it out. Okay, let's go ahead. This is definitely an acidosis. pH of 7.29 is very acid. The CO2 is the cause. 61, normal's 35 to 45. So 61 is a respiratory acidosis. The bicarb's 28. We say that 22 to 26 is normal. So there is a little bit of metabolic alkalosis compensation, but it's only partial because the pH is still outside normal limits. So first we'll make sure we're right, and we are. A big check mark tells us we're right. The pH and CO2 levels are acidotic. Primary mechanism, respiratory acidosis. The metabolic alkalosis is compensating, but the pH is not within normal limits. So here we go, folks. What we've got here is a patient who is underventilated. They're hypoventilated. The CO2 is way too high. So we would increase tidal volume or respiratory rate. If the tidal volume is set too low, we would increase that. If the tidal volume is good, we would increase the rate. Then we would take a look at pressure control ventilation. We would increase the PIP. If the PIP is already as high as we want to go, we would increase the rate. With an oscillator, we would increase amplitude and decrease rate. All right, that's how we fix things. Now let's go ahead, 7.36, 55 and 30. Give you a couple minutes to interpret that one. This may be our last one, actually, because we've only got about 3 minutes left. So take your time and interpret this. We'll come back and explain it to you. Okay, let's take a look at this one. 7.36 is on the acid side, but it is within normal limits. So it is on the acid side. It's going to be an acidosis, but it is within normal limits. The CO2 is the cause. CO2 is high. CO2 is respiratory. So it's a respiratory acidosis. Is there metabolic compensation? Yes, there is, because the bicarb has come out of its range to compensate. That's metabolic alkalosis compensating for the respiratory acidosis. Partial or full? Full. That's because the pH is now back within normal limits. So let's do this. Let's click to be sure we're right. We are pH at the low end of normal. Bicarb and CO2 levels tell us something abnormal is happening. The acidotic factor is the culprit, and that's respiratory acidosis. Normal pH means it's fully compensated by a metabolic alkalosis. This is the classic COPD blood gas. So here's the thing. On your test, they might give you this blood gas and say, what do you want to do? And the answer might be nothing, or maintain current settings, because this patient has compensated for themselves. This is their normal ABG. I think that's a pretty good example to end on, because likely the NBRC is going to give you something like that. Oh, it's sort of baiting you. You know, they're baiting you to see if you would increase ventilation, but you wouldn't, because this is the patient's own normal blood gas. All right. So with that, we'll stop the screen share, and I wanted to get these newest items to you because they are very likely to help you pass the TMC exam. That's what this is all about, is helping you to pass the TMC exam. I'll go back next week, up the review sheet to where we left off, but I wanted you to have these because they have just been recently seen on the TMC exam. These topics are very, very important to you, and I didn't want the class to get by without you having them. Okay, this will be considered video 9 of our series of TMC review sheet videos. So we now have a complete set of 9 that takes us up to item 491, I think it is, 491. We'll probably wind up going over 500 items No, 691. Item 691. So you can see this thing has really grown, but that's great because every one of these topics makes you better prepared for the TMC exam. That's why we're doing this. It's a lot of work, frankly, but it's worth it when you pass the exam. So with that, I will end the meeting and I'll see you in the discussion area.